1 in 4 black men will get prostate cancer.
1 in 4 black men will get prostate cancer.
1 in 4 black men will have prostate cancer.
1 in 4 black men will get prostate cancer.
1 in 4 black men will get prostate cancer.
1 in 4 black men will get prostate cancer.
1 in 4 black men will get prostate cancer.
1 in 4 black men will have prostate cancer.
So this follows on quite nicely from what we just heard about, completely by coincidence, that this is my area of interest in research. So first of all, thank you to the people of Grangetown and Butetown in Cardiff who recorded these for me earlier this week. So this is a big statistic, isn't it? 1 in 4 black men have a risk for prostate cancer. And this is what got me interested in research. So back in 2012, when I was much younger, wasn't growing a moustache, those sort of things, I was working as a research nurse at Velindre Cancer Centre, and had also spent some time in Bristol in prostate cancer diagnosis clinics. And I could count on one hand the number of black men that we were seeing in clinic, despite this increased risk. So what I wanted to know then was, why are we not seeing these men being diagnosed? What do men who don't have a risk for prostate cancer know about this risk, and how do they share this knowledge? I was lucky enough at that point to get funding to do some research from RCBC Wales and also from Prostate Cancer UK to try and find out what was happening in the communities. I did some research with African and African Caribbean men and also white men to try and see what the differences were. The findings showed that for the black men, they were much more interested in talking to each other about their risks for prostate cancer. This is what one of the men said to me: "We're just talking about black people and there's a difference," which I really hadn't understood. I hadn't really thought that actually there was going to be some differences in the way that people shared information. The black men were much more community driven. They were interested in sharing knowledge in their communities and learning from each other. Whereas the white men in my research were competitive in the way they spoke. In fact, one of my participants said, when you're in a group, there's always someone who will out-ill you, which was one of my favourite expressions when I did my research. There's always someone that's iller, that's going to be on more tablets, that's going to the doctors more often, that has more appointments. I can see you're nodding there. That's what you find, yeah. So, whereas the black men didn't talk specifically about their own health, but spoke to each other about the differences in the way that they understood and the way that they wanted to learn from each other. And this was an eye-opener to me because as a clinician at the time and now as a researcher, I was quite ethnocentric. I thought we all talk to each other and think about health in the same way. I hadn't considered that actually there was going to be differences across cultural groups. So what I've done since then, taking on my research journey, I'm now working at Cardiff University as a senior lecturer. And I started to work last year within a public involvement group. So I got some funding to get a group of men together, some of whom you heard in that recording early on, to sit down and talk to me about what research should we be doing to actually look at ways that we can most effectively share information amongst these group of men. How should this be done, and how should we do the research? So that wasn't specific research on its own, it was just saying, how should we do this? And what this group of men came up with was the way that they think they would react or act on information about prostate cancer risk was if it was shared in their WhatsApp community groups. Now this was a surprise to me because I'm not very good at social messaging, or in fact I tend to ignore WhatsApp, it's terrible. But they have quite a lot of these community groups. For example, they're Dominoes clubs. They're all communicating with each other using those. And that, of course, has quite a wide reach across the UK. They said to me, if you share messages, if we do it between each other on these groups, then we might be more likely to act on the information we're given. It'll start a conversation. So what I'm doing now is I'm actually working with these group of men, some of whom are going to be co-applicants on a research grant, to put up a WhatsApp group. So form a WhatsApp group which the men themselves will be responsible for, and share messages about their risk. Now, these are the messages that they came up with. So this is what they thought about what might happen if you have symptoms for prostate cancer. And this is what they believed that they would act on. Now, I think as clinicians and academics, we might think you can't tell someone that if you ignore the symptoms, it could lead to death. And in fact, other academics who are working on this project with me have said, you'll never get that through ethics. An ethics committee is never going to say you can share this information. And that might be the case, but obviously we'll be putting in all sorts of support mechanisms for this. But my argument is, but this is what the men have said they want to hear. Who is it for us to say what we should be telling them? These are what the community groups want to know. So what we're doing now is we're going to apply for pilot funding to form a WhatsApp group, share these messages with a small number of people, which the public involvement men will form, and we'll then do some research around the accessibility and the acceptability of these messages. So perhaps we get a broader idea that these aren't quite right. But we need to ask the people, just as the other speakers have been saying, it needs to come from the people that are going to most benefit from having this information. At the moment, of course, we don't have screening for prostate cancer, which is a shame, but I'm aware that there are quite a lot of developments going on at the moment, and perhaps in 10 years, there may be screening for prostate cancer. So my argument here is, why don't we set up a way of working with men that when the screening is available, those people that are at the highest risk will actually have a way of reading the information and acting on it. I also have an academic GP involved in this research, so that if we develop that into a bigger study, we will be able to work with them to say, how should we monitor behaviour change? How are we going to know that once the men have seen these messages, they're actually acting on it? So this has got some real potential in terms of developing. And for me, it's quite exciting because I'm building on what I really believe in is that, and as we've been hearing this morning, it's not us that should be making the suggestions, it needs to come from people. And that's what, as an academic, that's what really drives me. Why should we be going to people? Let's do the work with them. And I've done that all the way through, so far, all the way through my research career. It's not easy and it slows things up, unfortunately, because the communities I'm working with are not the sort of people who are usually registered for public involvement, but we're working around that, and that is something that really needs to change. And as we've heard already, people are and funders are now starting to see that. So that's something that I hope during this type of research we'll be able to see a difference with. Thank you very much.